Hello, everyone. Welcome back to our class. This will be the very last topic that we will discuss for the whole semester. Then you will have your final exam on January 29, so sunod nga meeting or next Saturday. And then, before you take the exam on January 29, final exam na, no more pre-finals. Before you take, submit on the day of the exam or before the day of the exam, an outline, bulleted format, again, bullet format, outline of all we have discussed sa incompatibilities or interaction like drug to food, drug herb, etc. From the beginning sa incompatibilities up to drug interaction. Make an outline, font style Times New Roman, font size 12, spacing 1.5. Then no no limitation sa pages basta kay naatanan na akong gipangayo nga content like drug to food, drug herb, drug the drug test, not drug test, drug to diagnostic test interaction, and then drug to drug interaction. So katong na-discuss nato so far up to kanisiya na topic. Again, that will serve as your quiz, long quiz na siya. Make a good outline para dako po inyong score. And then finally, I will repeat the schedule of the final exam on Saturday, January 29 na siya ata, next meeting. So this will be our last topic na for this semester, drug-to-drug interaction. So let's start. So definition refers to an adverse response produced by the administration of a drug or co-exposure with another substance which modifies the patient's response to the drug. So again, we have the precipitant drug and the object drug. Not necessarily precipitant drug lang, but we have a precipitant substance, and then, of course, ang how you call this Bisaya, ang mudawat sa interaction or the object of the interaction is that object drug. So yes, again, precipitant drug plus object drug, there is drug interaction. Precipitant drug is the drug, chemical, or food element causing the interaction, and object drug is the drug affected by that interaction. So drug interaction includes, muna itong i-discuss, drug to drug, drug to herb, drug to food, drug to genetics, drug to alcohol, drug to diagnostic test, etc. So, unsay possible outcomes of drug interactions for a while sa Okay, so what are the outcomes of drug interactions? First, we have loss of therapeutic effect, toxicity, unexpected increase in pharmacological activity, beneficial effects such as additive and potentiation or antagonism, and then chemical or physical interaction. So classification of drug interactions, we have pharmacokinetic or biopharmaceutical. So interactions occur when the absorption, admin na siya. Kulangan og metabolism here. When the absorption, actually it's LADME, liberation, mag-start siya sa liberation kung oral. But kung dili siya oral or kuan siya, intravenous or parenterals, dili na siya kailangan liberation, diretso naman siya. Okay? So again, interactions occur when the absorption, distribution, or elimination of the drug is affected by another drug, chemical, or food element. Kung pharmacodynamic, interactions occur when the pharmacodynamic effect of the drug is altered by another drug, a chemical, or food element producing an antagonistic, synergistic, or additive effect. So another classification of drug interactions is pharmacogenetic. So interactions occur when the pharmacokinetic effect of the drug is altered by genetic polymorphisms in affecting processes. And lastly, we have pharmaceutical interactions are caused by chemical or physical incompatibility when two or more drugs are mixed together. So kung pharmaceutical, it has something to do with sa drugs na gid mismo. Sila together, when added, there's incompatibility. Nothing to do with how it is being affected inside the body. So pharmaceutics. So for pharmacokinetic drug interactions, mo ni siya usually ang involved. And now we start with pharmacokinetic interactions. So first we have altered GIT absorption. So na alteration sa pH, na altered bacterial flora. There's formation of drug chelates or complexes, drug-induced mucosal damage, and altered GIT motility. So altered pH sa imuhang gastric, sa gastric juices nimo, your stomach, inside your stomach, or in bacterial flora, in your, let's say, intestine, something wrong. Namagoy uban bacteria nga mo help og pa-absorb sa uban tambal. Next is formation of drug complexes. So kung mo-form siya complex, of course, di siya ma-dissolve. Kaya kailangan man, before siya ma-absorb, it should be dissolved. In solution dapat ang imuhang drug kung oral siya. So kailangan siya first ma-liberate from the dosage form. Munang natay pang-add nga disintegrating agent sa ato ang drugs. Kay if wala disintegrating agent and then binded kay imuhang drug product, then di siya ma-release. Dili siya ma-dissolve or ma-make into solution form. Kay ayha raman siya ma-absorb kung ma-liberate ang imuhang tambal or the active ingredient or the one producing a pharmacological effect, and before ma-dissolve siya, form into solution form, ay siya ma-absorb sa imuhang body. Next, mucosal damage. Of course, if there's something wrong with the lining of your stomach, then how will it be absorbed? And then altered GIT motility, something wrong with the motility of your GI tract. So paspas ka iyahang flow, dili siya maka-dwell kintahay sa imuhang stomach. Paspas iyang flow, if need siya i-absorb sa imuhang stomach or kailangan siya kanang mudiretso or paspas siya mo agi padulong sa imong intestine kay dito siya ma-absorb. But something wrong with your GI tract motility, like nagdugay na noon siya sa stomach or wala siya ka exposed kaayo sa gastric juices, that depends po sa klase sa drug kung asa siya ma-absorb. Natay enteric coated, dili siya ma-affected sa gastric juices. Kay if dili nimo enteric coated, madaot ang drug, ma-deteriorate siya sa low pH. Dito ra siya ma-dissolve in the intestine na enteric coated. Next, so in specific, altered pH. So the non-ionized form of a drug is more lipid soluble and more readily absorbed from GIT than the ionized form does. So muna siya mahitabo in the absorption, non-ionized form, more lipid soluble ang mas readily absorbed kaysa ionized form. An example, we have antacids. Antacids increases the pH of your gastric, sa imong stomach. Kung increased ang pH, there's a decreased dissolution of ketoconazole. Kaya need siya og acidic medium in order to dissolve the tablet ketoconazole. Same sad with your H2 antagonist, antacids, of course, anti-acids. So, mahimo basic or a little bit alkaline. So, i-higher niya ang pH. Kaya diba, gastric good. So, acidic na siya. So, low pH. Kung antacids, yan isa kagamay ang pH. Ang H2 antagonist, lower the pH. Next, therefore, these drugs must be separated by at least 2 hours in the time of administration of both. Kung antacids niya, mag-take ang ketoconazole, at least 2 hours separate nimo ang pag-take. However, you can use H2 antagonist for a while. So some drugs require an acidic environment for optimal absorption in the GI tract. Example, ana, your itraconazole, ketoconazole, tazanavir, H2 blockers and proton pump inhibitors reduce absorption of these drugs. Ay, did I mention nga ang H2 antagonist mo lower sa pH? No. Sayop na siya ha. Kay H2 antagonist man mo po na, di ba, pang gamiton po na siya for, especially for how do you call it, ulcer ba na siya? Gastric, ulcer. So, kung di na matabang og antacids, diha na din ka, ipatake na din ka mga omeprazole, mga ranitidine, etc. Okay. GI motility. So, decreased GI motility via methadone increases didanosine degradation and reduces didanosine bioavailability. So, example, decreased GI motility tungod sa methadone, pag-take, i-increase ang didanosine degradation. Ganun man, kay decreased ang GI motility. Dili siya bioavailable. Siya ma-absorb kaayo kay decreased GI motility man. So, mas slow down ang movement sa imuhang GI tract. Decreased GI motility. So, mas ma-expose siya, let's say, kung sa gastric acid. Kung increased GI motility by metoclopramide, this one reduces digoxin absorption. Again, increased GI motility by metoclopramide reduces digoxin absorption. So drug interactions that affect bioavailability of the drug from the gastrointestinal tract. So example, drug interaction on alteration of gastric pH, precipitant drugs, H2 blockers, antacids, and PPIs. Effect ani, increased gastric pH. So saka ang pH, ma-basic siya somehow. Not necessarily maabot siya sa basic, but instead of the actual pH of the stomach, which is acidic, ma-increase siya gamay. Dissolution of ketoconazole is reduced at basic pH, causing decreased drug absorption and therapeutic failure. Ketoconazole, what else? Ito earlier? Itraconazole and atazanavir. So, muna siya ang object drug. For increased GI motility, example, you have laxatives and cathartics. So this decreases bioavailability for drugs that are absorbed slowly, especially for controlled release products. Okay, paspas man ang GI motility. So dili siya ma-absorb kay giigo. Kung GI motility paspas, sige kag I call this, mas magdali ka maglibang or defecate. Sorry for the word. Decreased GI motility, mga anticholinergic agents. So, propanthelin decreases the gastric emptying of acetaminophen. Again, propanthelin decreases the gastric emptying of acetaminophen. Thereby delaying absorption from the small intestines. Again, propanthelin decreases the gastric emptying of acetaminophen, delaying absorption from the small intestines. So for drug-induced mucosal damage, an example would be your antineoplastic agents like your cyclophosphamide, vincristine, and procarbazine. So this induced drug-induced mucosal damage will inhibit absorption of several drugs like your digoxin. Kung altered motility, again, metoclopramide, antiemetic na siya. So di ka magsuka-suka. Increases the toxicity of cyclosporine tungod kay na-increase ang absorption of cyclosporine due to the increase of stomach emptying time. So alteration of intestinal flora, example would be your antibiotics. So mo na iyang i-cause. So ang effect ana, digoxin has better bioavailability taken after erythromycin. So erythromycin administration reduces bacterial inactivation of digoxin. Another is estrogen or progestin birth control. So requiring intestinal flora to facilitate enterohepatic circulation. So antibiotics reduce intestinal flora and reduce estrogen progestin level. Another, inhibition of drug metabolism in intestinal cells. We have your monoamine oxidase, your tranylcypromine, and phenelzine. So this one inhibit metabolism of albuterol and valbuterol, leading to hypertension. Now we have chelation. For chelation, this is irreversible binding of a drug in the GI tract. Sa mga involved, usually tetracyclines, quinolone antibiotics, and ferrous sulfate. So iron, or you can get from ferrous sulfate, and then from antacids, your aluminum, calcium, and magnesium, and dairy products, your calcium. So usually separating administration of chelating drugs by 2 hours decreases interaction effect. So kung mo take gani ka og quinolone antibiotics or mga tetracycline, dili ka dapat mag-inom og gatas. Use water. Then di po nimo siya isabay with antacids and of course ferrous sulfate. So mga, let's say, kuan ka ng take ka og tetracycline, then inom ka gatas, nakilate na, nagidungan yun. Nakilate na, na-conform into chelate or complex. So, di siya ma-absorb. Ning kuan man siya, ning complex man siya. So, di siya ma-form into di siya ma-dissolve. Di siya in solution form. So, lisod siya i-absorb. So, complexation or chelation, example, tetracycline interacting with iron preparations or milk. So, there's an unabsorbable complex. Another is antacid, your aluminum or magnesium hydroxide. This one decreases absorption of ciprofloxacin by 85% due to chelation. So drug interactions that affect the bioavailability of the drug from the GI continuation, we have complexation, chelation. Precipitant drugs, kind of mga calcium, magnesium, or aluminum and iron salts. Object drug, we have levofloxacin, complexes with divalent cations in the diet, like your calcium, causing decreased bioavailability, or minum kag iron supplements. Next, we have sodium polystyrene sulfonate. So cations in antacids bind to sodium polystyrene sulfonate, causing reduced renal clearance of bicarbonate, resulting in systemic alkalosis. So dili siya maayo. Kay ma-reduce ang excretion of bicarbonate. So high bicarbonate presence or bioavailability in your system will result to alkalosis. So kuan mo ang blood, basic, very alkaline. Next, we have anion exchange resins. Example, your cholestyramine. Form insoluble complexes and therefore reduces drug absorption. For example, warfarin, digoxin, beta blockers, and NSAIDs, and then immunosuppressants. Your cholestyramine sometimes used to treatment of Clostridium difficile colitis. This interaction could result in deficient or decreased activity of your immunosuppressant absorption and possible graft failure in transplant recipients. For absorption, we have cholestyramine, decreased bioavailability of digoxin and levothyroxine. Kaolin or acarbose, same for digoxin. And activated charcoal, decreased bioavailability of many drugs. Adsorption, sorry, not absorption. Next, we have altered distribution. For altered distribution, this is preventing accumulation in a sanctuary or your receptor site. In specific, kanang mga plasma protein binding and other displacement interactions. So displacement of albumin and alpha-1 acid glycoprotein carrier proteins. Mo na siya ang involved for the distribution, your plasma proteins. So valproic acid displaces phenytoin from plasma albumin protein binding site, so competitive inhibition, and reduces hepatic phenytoin clearance, resulting in higher phenytoin levels. Aspirin is 90 to 95% protein bound and displaces warfarin from protein binding sites, resulting in higher warfarin levels. Second na involved sa distribution, I think na-discuss na ni sa inyong biopharmaceutics or next semester pa ba? I'm not sure kung kano sa inyong biopharmaceutics. So protein binding is involved in the distribution. And then we have tissue and cellular interaction. So digoxin toxicity can be enhanced by concurrent administration of quinidine. Quinidine reduces digoxin clearance and displaces digoxin from both alpha-1 glycoprotein and albumin tissue binding sites, leading to a higher plasma digoxin concentration. Okay? Quinidine, unsa gani na siya? Quinidine, familiar na ninyo? So transport proteins. Efflux, so it extrudes out drugs outside of the cell. So ipagawas niya. Uptake facilitates intracellular movement of molecules. So ipasulod sa cell. So drug transport, efflux. So an ATP binding cassette protein or the MDR1 gene product. So this one located in GI tract, your blood-brain barrier, BBB, liver, kidney, lymphocytes. So transports many chemically diverse compounds. This one may affect the absorption, distribution, metabolism, and your excretion of substrates or your drugs. So substrates in particular, we have digoxin, colchicine, fexofenadine, and talinolol. So inhibitors for this one, cyclosporine, verapamil, erythromycin, and itraconazole. Inducers, your phenobarbital, rifampin, phenytoin, and St. John's wort. For drug transport uptake, so transports numerous amphipathic compounds. Some present only in the liver, many present at the blood-brain barrier, lung, heart, intestine, kidney. So facilitate the influx of compounds. So fexofenadine and digoxin are well-defined substrates. So transport uptake substrates. Fruit juices inhibits OATPs along with quinidine, nilfinavir, sakinavir, and ketoconazole. So ano siya? OATP. ATP binding cassette protein. Next, fruit juices. So example is your grapefruit juice, apple juice, and orange juice. Reduces fexofenadine absorption. Still inhibits the protein. OATP1B1 uptakes drug into the hepatocyte where it then undergoes subsequent metabolism. So blockade of this transport protein results in reduced metabolism and increased plasma drug concentrations of your rosuvastatin. So displaced protein binding. So depending on the affinity of the drug to plasma protein, the most likely bound drugs is capable to displace others. So competitive siya, inhibition. The free drug is increased by displacement by another drug with higher affinity. So phenytoin is a highly bound drug to plasma protein, tolbutamide 2 around 96% and warfarin 99%. These may displace agents such as sulfonamides and phenylbutazone. Next, we have altered metabolism. So, kaning pharmacokinetics has something to do with LADME or ADME. So, drug metabolism can be affected by enzyme induction, enzyme inhibition, substrate competition for the same enzyme, and changes in hepatic blood flow. So, typically occurs in the liver or GI tract. First, we have inhibition. So, enzyme inhibition occurs when two drugs sharing metabolism via the same isozyme compete for the same enzyme receptor site. So the more potent one or the more potent inhibitor will predominate, resulting in the decreased metabolism of the competing drug. So for most drugs, this can lead to increased serum levels of the unmetabolized entity, which may lead to toxicity. For drugs whose pharmacological activity needs prodrug or biotransformation to form into prodrug, inhibition can lead to decreased efficacy. So na again, prodrugs needs biotransformation ay siya mo activate to the actual drug na ma-distribute throughout the body. Kung dili siya mo-form into prodrug, then of course, decreased efficacy of that tambal. Next, competitive binding to enzyme site. This one typically occurs quickly, depends on the time to steady state of the inhibition. So time to maximum interaction effect dependent on the time required for substrate drug to reach new steady state. So unsay mga enzyme inactivation, usually your grapefruit juices are very notorious for enzyme-induced na mga interaction on grapefruit juice. So we have the substrate, despyramine, iyahang enzyme is CYP2D6, your isozyme. Phenytoin, C2C9, midazolam, caffeine, voriconazole, efavirenz, and amitriptyline. Muna siya ang mga particular enzymes. So enzyme inhibition of the following result in the significant increase of your drug in the your system. So it could be potentially toxic, and if these drugs need formation of a prodrug, then di siya effective kaya wala man siya na form. Kaya wala siya na biotransform. So some examples of strong inhibitors for CYP1A2, we have ciprofloxacin, fluvoxamine, gemfibrozil, fluconazole, omeprazole, rabeprazole, lansoprazole, fluoxetine, itraconazole, ketoconazole, HIV protease inhibitors, and clarithromycin. So these are the following enzymes na i-metabolize ning ciprofloxacin, fluvoxamine, your CYP1A2, and then etc.